This discussion will focus on mental health and substance abuse. I would like to invite our moderator for this session, Mr. Ruben Dickinson, the VP of Strategic Partnerships at Telemind, to introduce our panelists and open the session. Let's give him a round of applause.
Okay, panel 4, just 3 hours remaining, right, Kenneth? Yeah, okay. Okay, so everyone, before I let the panel introduce themselves, I'd like to share with you, I'm former Army, so family support for me was when I was a single adjutant, brand new battalion S1, family support wasn't even on my radar. So we're in Germany, we go to Reforger. Out on Reforger, one of our crucial MOS soldiers got a call, actually the TOC got a call, that his wife, who had just gotten into Germany, living on the economy, only had popcorn to eat for her and her 2 small kids. I learned very quickly as the Battalion S1, also known as the whipping boy in a lot of battalions, I learned very quickly how important military family support was. Thank goodness for all of the spouses back in garrison. They pulled together, took great care. So I saw the need and I saw the solution in action. So that was just absolutely awesome. So what I'd like to do before we turn it over to Brooke is just go down through our panel. We have a great panel here of experts. So please, would you like to kick us off, sir?
Sure. Hello, everybody. My name is David Kendrick, former Army as well. I know we're in the land of infantry, but I served in the cavalry. Served as a cavalry scout from 2005 to 2010 out of Fort Carson, Colorado. And now I am associated with NAMI. We're the National Alliance on Mental Illness. We provide free programs and services for those living with and caregivers and family members of those living with mental illness.
Great, thank you. So my name is Captain Megan Corso. I am DHA's Chief of Behavioral Health, so I work for General Crossland. I'm a clinical psychologist by training, still active in seeing patients. And I would say that my most important title, though, would be that of a mom, so of 3 kids. And so balancing it all is certainly a challenge in a way that I can relate to folks. But I'll hand it off to you.
Which
Hi, everyone. My name is Chris Biena. I'm also a clinical psychologist at the DHA. Megan and I work together under, Dr. Kortz is our director for medical affairs, but we are housed in the DHA. Most of my work at DHA is about pediatrics and complex care needs, so transitions of care, programs that associate with those other military, the service programs, so like EFMP, EDIS, those types of programs. And I'm thankful to be here and talk about what we are doing and the amazing things that we have ahead of us. So thank you.
I am Dan Rose. I'm another clinical psychologist. There's a lot of us up here. What that means? I was a Boy Scout in the KISS Army. I don't know if that counts. I am, but anybody else in the KISS Army? Anybody? Yeah, you go. Okay. Kind of. I still got my fake tattoos. I am at Columbus State University. I'm the director of the counseling center there. I teach in the clinical mental health program. I also am part of a large private practice called Columbus Psychological Associates, and I've worked with families and the military through that service for almost 30 years. Started when I was 12.
Hello, everyone. I'm Harry Tatum, Sergeant First Class, retired. I've been out of the military for about 21 years now. I am the program director for our residential substance abuse services, student utilizing behavioral health. I am a master addiction counselor, and I'm licensed as a counselor.
Hello, everybody. My name is Susan Gallagher, and I am an accountant. Don't ask me how I got on this panel. I am a community QPR trainer. That is an intervention, community-based intervention, question, persuade, refer. That is a suicide prevention and awareness for anybody who's non-clinical. I work at New Horizons Behavioral Health. We are part of the Public Mental Health Safety Net, part of the Georgia Department of Behavioral Health and Developmental Disabilities. and I have worked at the agency for over 20 years and really support our mission of building better lives. So thank you for letting me be up here with all these clinical folks.
So you did that.
And good afternoon to each everyone. My name is Dr. Terrence Elliott. I am a substance abuse prevention specialist for the Army G9. I was actually with the G1 up until here 1 June, and now became an asset of Army G9 in the substance abuse arena. I am prior service. This was my last duty station that I left in 2001. So coming back, it's been a great and different experience. But of course, my responsibility as far as substance abuse goes, I'm the prevention PLC out of the G9 for primarily prevention resources that are available for service members as well as government civilians. And in some assets, or should I say aspects, there's some things that may be available for family members on space available. So it's wonderful to be here this afternoon to be a part of this panel. Willis, I do have a background as a credentialed Christian counselor, and I'm also a credentialed chaplain. I have a few other things in that wheelhouse of credentials, but once again, it's great to be on this panel to represent the Army G9.
I want to add something too, I forgot. I'm prior military. I was active Army as a medic in Germany. Then I was an active reservist for about 4 years, and I was also a military spouse. So I've kind of seen things from both sides as the active duty member and then as the family member.
And believe it or not, even though we have the whole table filled here, we're actually missing Ms. Carrie Schultz of the Army Resiliency Program. She got caught up in the storms. So we will miss her. We'll carry on, though, in her absence. So I'll turn it over to Brooke for some stats and data.
Thank you. I'm excited to talk to you today about mental health. I will add that I was a clinical social worker for 6 years, so excited to be on a panel with esteemed clinical social or mental health practitioners. So as you can see, this year we asked our participants, do you currently receive mental health care? And of our active duty service members, 22% reported that they do receive care, while 17% reported that they would like to receive mental health care. And as you can see, 23% of our active duty spouses reported that they received care, while nearly 25% of the spouses reported that they would like to receive care. We didn't ask them for the reasons why that they didn't receive care like we did in 2021, which you can see some of the top reasons that they didn't receive care was it was difficult to get time off from work. It was difficult to schedule an appointment. Childcare was a reason. Another reason was the treatment wasn't sensitive to my needs in terms of not finding, there were no female providers. And as you can see on the left, 21% of active duty family respondents would like to receive mental health care, but currently do not. Oh, what happened? Sorry. Here we go. And this last year, we asked about children not receiving mental health care. Nearly a quarter of active duty family respondents with at least one child enrolled in K through 12 had a child receiving mental health care, while 16% of active duty family respondents with at least one child enrolled in K through 12 reported that their children currently did not receive care but would have liked to receive care for mental health, to receive mental health care. And one of the reasons was that they couldn't find an available mental health care provider. It was difficult to find an appointment.
telehealth care just wasn't an effective measure for their child, or it was difficult to find child care for their other children, or there was a wait list for the provider. I've also spoken to other providers, and I know we talked about this earlier today, and one of the reasons was the reimbursement, the TRICARE reimbursement rate. The reimbursement rate is incredibly low, and so they won't take, civilian providers won't take TRICARE reimbursement, and so that makes it really difficult to find providers as well. Another thing that we looked at this year was, in terms of children's mental health, was bullying. 1 in 3 active duty family respondents saw that their children experienced bullying on school property. 1 in 12 reported that their child experiencing bullying online in the past 12 months, along with 24% of active duty family respondents with at least one child enrolled in K through 12 reported that their child had experienced racial and ethnic motivated bullying in their civilian community, along with 14% reported that their child had experienced racial or ethnically motivated bullying in their military community. One of our findings in our latest MFLS was on support circles. 81% of our active duty family respondents reported that they had a close friend or a loved one experiencing one or more stressful situations. We know that military families rely on each other first before seeking formal supports, and we wanted to see not only how military families provide supports for one another, but how confident they feel in providing these supports. And so we found that 1 in 5 active duty family respondents reported having an adult or family member experiencing or expressing suicidal thoughts, or making a suicidal attempt, or die by suicidal ideation, or die by suicide in the past year. And when we asked them how confident they felt in helping their friend and loved one through a mental health crisis, just 25% reported they felt very confident. So, because of the rising concern of suicidal crisis for veterans and active duty service members, we wanted to dial in on those friends and family members. So we Blue Star Families applied for the Staff Sergeant Fox Grant, which we were awarded last year. We developed the Blue Star Support Circle program, which helps these families of veterans provide confidence in these families, and to help these loved ones provide them the tools and resources that they need. So here is it's an 8-week program, and it provides sessions such as having conversations about mental health, identifying the signs and symptoms of suicide and self-harm. They talk about self-care, music therapy, how to safely store your firearms. We provide them lock boxes, having conversations about firearms storage, about not identifying it as placing blame on the veteran, but really that it's good family practice, and identifying safety plans for the family and coping with stress, along with practices on suicide reporting and asking for help, and identifying community resources. We feel that this would be a wonderful plan to replicate with our active duty families. And so we are advocating that this should be So right now it's a program for veterans, but like I said, we are advocating for a policy for our active duty families. We also have a campaign awareness for a national mental health awareness campaign that's being launched right now that increases engagement with mental health resources and reduction of surrounding mental health and decreasing suicide rates with our target audience as well. And that concludes our data.
Okay, thank you, Brooke. So I served 5 years in the military and then separated in the Army, separated and then went into healthcare. Now, to be all-inclusive for the good Congresswoman, I do have a Naval Academy midshipman son, our youngest. We've, of course, cut him out of the will and excommunicated him, but so, yeah, be Navy. So one thing that is really interested me as I introduced Telemind, our company, is the fact that 5 years ago, Telemind was a small startup. After years at GE, Thermo Fisher, etc., because I grew up around severe mental health care issues. When I got a call from a friend from GE days who said, "Hey, got a small virtual therapy and psychiatry company. Are you interested in coming in, helping me shape it for the future?" So as soon as I got there, I said, "This is perfect for the military." So we consciously chose to do two things with Telemind. We chose to keep our costs low so we can operate at TRICARE CMAQ rates. And then number two is we adopted a high support model. So we want to be simply the people who pick up the phone. So warm-up question. So right now we're seeing hundreds of thousands of military community members, beneficiaries on an annual basis. Anybody want to guess how many we saw in 2019? Give me an over-under. Approximately what? Shout it out. Good question. Or good answer. Good answer. Keep going. One more. 100,000. Okay, thank you. I think the number that we can, as best we can measure, is 27. So in the course of only 5 years, we have gone from basically zero, let's call it zero, to hundreds of thousands because of the need, because of the mental health care crisis in the military and our intentionality in serving to fight that. So just a couple of things, and then we'll go through some Q&A here. So we, on the age, as everyone's had conversations, or so many people have said, "Hey, what ages?" and talked about difficulty finding child adolescent coverage. We serve ages 5 and above. We are nationwide. We are live with therapy and psychiatry in all 50 states. Okay, we have the first question. Yes, please.
So are you in school?
We are virtual, so we are everywhere. Oh, and do we have one? Contracts with schools, or we have no contracts with schools. Our partnership for TRICARE is through Humana Military in the East region, as well as then HealthNet in the West. Great question. Thank you. Wow. Okay. So personalized intake, again, we answer the phone. We want to be high support. And so we are live nationally with both TRICARE and now with the VA through the Community Care Network. So that's Telemind. So thank you for listening. So to kick us off, a couple of questions. And we have a microphone that'll be circulating around. Okay, well, we didn't get to my questions. Yes, ma'am. I love it.
So again, as a recap, I was a military brat. Now I'm a military spouse. I'm a licensed professional counselor. Then I've been off 15 years. My question is, every time I have gone to the bases and been around that area, there seems to be a propensity, specifically with the Army, so I researched this, with other branches, to hire social workers and not licensed professional counselors, which I find very interesting because there's a shortage and a need for service members, specifically Army, and spouses and their children. And the highest license rate when it comes to mental health professionals, the ones that have the most licenses in most states, is licensed professional counselors. And as a spouse and a licensed professional counselor, having found it difficult to get on board on a base with all of my experience, being a certified trauma therapist, all of that, my question is, who handles that process where it's just like, because the thing is, historically, it's been social workers. We know that. It's been that historically. The VA hires licensed professional counselors. Again, Air Force bases will hire licensed professional counselors. You can be a military family life counselor, right? Which handles non-crisis needs. I've been one on multiple bases in the schools and for the unit. But how does one be an LPC? So who handles that process?
Please.
Great question. And so I think one of the things that you're highlighting is an opportunity that exists within DHA and the transformation of the military health system. So rather than MTFs being managed by different services, different policies, different regulations on credentialing, which is really where I think you're going in your question, we have an opportunity to standardize that. So you walk into an MTF on an installation that's Air Force versus Army, and you'll see that the credentialing process is going to be exactly the same. In the last year, we have opened up within the military treatment facilities both licensed professional counselors as well as LFMTs. So we now actively credential them in addition to social workers, psych NPs, psychiatrists. We're expanding the pool of behavioral health providers and trying to recruit them into the direct care system. And when I say direct care, I'm really referring to our 450 military treatment facilities worldwide. And so we do now credential and recruit LPCs into our system to help us treat in specialty behavioral health clinics. But I do want to take a moment, though, and allow Dr. Biana to comment on the TRICARE network side, because I think that's part of the piece as well.
Thanks. I think the TRICARE network side, there's several categories of eligible provider types. The one consistent variable is that they have to be licensed, right? They're from your psychologist, your social worker. They're called TRICARE certified mental health counselors. That's where most of those LPCs are going to fall. So standardization, of course, but lots of opportunity within the TRICARE benefit too for LPCs in particular.
Okay, thank you. And that also leads to TRICARE needing to change their credentialing process because it's horrible.
Okay, we have a question in the back.
Good afternoon. My name is Renee Daughtry. I'm the school liaison program manager at Robins Air Force Base. And can you elaborate a little bit on the simplified access? Because we've got MBLACs in 21 of our schools, but again, they provide non-medical counseling to students with social and emotional or even academic issues. But when they need something more or some type of mental health service, it's like a 3-month wait in our area to get them in to see somebody professional. So seeing this, saying that they don't need a referral with their family members, can you elaborate on how they go about, because I would love to be able to maybe recommend to parents that this is an option for them so that they don't have to wait so long.
I think that's you too.
Yep, I'll take that question.
Okay.
So yes, we got rid of so it used to be called the unmanaged aid policy, that family members could go to see a mental health, an office-based individual provider. So, your therapist, your social worker, psychologist, LPC. You could see them for 8 sessions and then have to have a referral. Well, that changed in 2016. And so for that particular level of care, there is no referral except for active duty for dependents and retirees to go get that care. Having said that, I think the issue is, who do I call? Where do I go? What if I call somebody and they tell me I have a wait? Well, I want to say good news, but I know there's a silver lining. There are multiple options and ways to go about getting assistance. So one, through the MTF, there are beneficiary counselors available. There are through EFMP, they actually have health benefit advisors. So there are lots of types of individuals who can help access. That's on the direct care side. On the private sector side, in TRICARE, call the managed care support contract, call Humana, call Health Net and say, I need help finding a provider. Some folks have case managers or care coordinators. Those folks are available. If you're registered at ECHO, you have access to an ECHO case manager. So there are lots of folks. People just need to know who to call. And I think that's the hardest. It's so overwhelming. You Google and you can get a whole lot of information, but where do I point my direction?
Good. Yes, sir. While the microphone's coming back there, I will. Oh, you don't need one. Yes, sir.
Hello. My name is Jeff Gibson. I'm a chaplain. I got 2 questions. You get a call, a spouse, called second combat tour, killed himself in front of her and did. she got 30 days to get off post. We should get the help there. Second of all, second question is, you get a call from a veteran contemplating suicide, the medication they give you, the side effects of suicide ideation. Thank you very much.
So while she gathers her thoughts, that's one of the things that I had said about Gold Star families, is that it seems to be, what I'm hearing all day today is a disconnect between services and what the service members and family members know what's available.
And I think that question regarding the family that would have to leave base within 30 days, that goes back to the panel that was here before and some of those issues that we want the elected officials to address. The Love Lasts bill, the Love Lives On Act, yes. So that would address some of those issues, but that's a very difficult thing. Now, remember, I'm not a licensed clinician. My background is going to be somebody that speaks in the community around having conversations of courage, and I really like seeing what the Blue Star families said around combat the silence. And that's what we've tried to do with these conversations of courage and having the QPR training available in the community. One of the things that the Blue Star PowerPoints don't know how to talk to somebody in a mental health crisis. They don't know what words to use. Sometimes they're afraid to address those issues. We need to speak from the heart when somebody is telling us that they no longer want to go on, they no longer want to live. One of the things that the training that the Blue Star families is doing is around, I call it keep calm. It's control access to lethal means. And we have to think not only of the access to firearms and locking up the firearms, there's also medications, et cetera, that can be used. Firearms are usually the choice of the male population around death by suicide. Women are more likely to try to overdose on pills or maybe suffocation. So you need to control access to lethal means, all lethal means, not just firearms. There are more opportunities for somebody that wants to end their suffering, because the problem is not suicide. The problem is the individual thinks that suicide is the only solution to what they feel is an impossible situation.
Ruben.
Can I just make one comment to gentlemen? I just want to check in with folks. Is anybody in the audience aware of the In Transition program? Anyone ever hear of it? Okay, so just one comment on the In Transition program. This is a program that exists 365 days, 24/7. They are open and answering the phone. And what their job is, it's a call center. There's help coaches. They will help you transition your care from the military to the VA, to a civilian provider in the community that you're going to. This is really there to help try to address those gaps in transition. We know that can be a high-risk time for folks, and so we really want to surround a service member, family member, veteran, as they make that transition from one healthcare system to another. They can leverage that program, and they will help coach you. They will help you find a provider in your local area that will help support you in transitioning your care over. So that would be one resource that would be available for that type of situation.
Bro. Yeah. So 10 years ago, I sat on the SOS committee that changed the rule that when you lose a soldier member, you can stay in the housing up to a year. Now, if that isn't true, somebody tell me. Yeah. So we worked on that because I grew up in an Air Force family. And when we had a plane go down, in 2 weeks, that family had to be off base. And we changed that.
Okay. Willis Sheldon. I'll get you next.
I know everyone's tired of hearing this voice today.
But I hear one side saying there's a focal point to get information, and I hear one side saying there's a ton. I think biggest problem we have here right now is information overload. We need a focal point so people can get to a spot and get to what they need and be pushed or led to what help they need. But having 21 agencies they need to sort through to get the information they need is a bit much. Because when you're in the thralls of that depression, that suicidal state, that's going to push you even further.
Right.
And I'll tell you this right now, I'm sure. I speak from experience. Until I got to a focal point that I had one person controlling where I branched to, where I got my help from, things did not calm down. But I had multiple people telling me, when you get help here, help here, it was like, you're not helping me. And that was part of the problem. Thank you.
Thank you. Will,
On the civilian side of things, in the state of Georgia, we have the Georgia Crisis and Access Line. It's like a single silo where all sorts of information can be gathered. And if you have any concerns, mental health or otherwise, they sort of hook you up with whatever agencies they can. And even if you're not in the state of Georgia, you can call that and they can look you up to a comparable program in whatever state you happen to be. One of the benefits of that is there's someone who could directly deal with a crisis if you're experiencing it. They can also hook you up with whatever resources you might need, temporary housing. They'll even be able to set up individual counseling appointments with adults as well. So, and it's GCAL, Georgia Crisis and Access Line.
It's 988. It's a national number now. The law has passed. I believe it came in effect last year in July. 911, you can call for if you're having a mental health crisis, a suicide crisis, a substance abuse crisis, anywhere in the country, you can call 988. And if you're an active duty military member, or I'm sorry, if you're a veteran, when you get the 988, it will ask you if you're a veteran, and you select option number 1, and it'll connect you automatically with the VA crisis line. So anywhere in the country, you will call 988 to access the crisis line. And thanks to our members in Congress for making that 988 possible and streamlining access to the crisis services.
okay, thank you. Yes, and you've been very patient. Thank you.
I deal with a lot of veterans. And is it the proper process as you have to have a healthcare provider in order to receive mental health care in the VA? But the person from VA is not here, so I'm not sure if anybody can answer that accurately. Because I have a lot of veterans who see doctors on the civilian side, but they prefer to see a mental health counselor or get some kind of group treatment on the VA side. And they're telling them, if I remember correctly, they told me that they were not able to get the mental health treatment that they need because they didn't have a VA doctor.
So I definitely can't speak for the VA, but I would be happy to take that question back to our partner. We do meet very regularly with the VA, so I do have that counterpart on that side that I can go ask, and I can confirm that for you. So if you catch me after, I will make sure that I find that out.
I will do it.
Okay.
All right. Thank you.
And thank you for the question. I can clarify from the provider group standpoint, they do have to have an authorization from a VA physician. So it has to come from the VA. And
Supply and demand. They don't have
I understand.
Provider available, and we have to wait 2 months down before you get that. And by that time, that veteran can have a crisis and start hearing.
I agree completely. It's a shortfall. I mean, I do agree. Please.
A little bit because I'm dealing with that right now as a veteran. So we just had a really big case over the springtime in Atlanta where a veteran and his mother were looking for treatment for a long time. And with the VA being backlogged, they went into the civilian community. This veteran was late to an appointment. He couldn't be seen. He returned with a weapon, shot and killed the receptionist, and shot 3 other people. And there was a big manhunt in Atlanta for him until they found him. that dispatcher goes to the same VA that I go to in Atlanta. It's in DeKalb County in Decatur. And I have the same issue where it's very, very backlogged. And then the issue that we have, if we want to go see a community service provider in the community, we have to get a referral. But then the referral process takes forever because you have to wait to see your primary care doctor, which would be 2 months. And then they have to make a referral, which would be another 2 months. And then you have to wait until that provider becomes available, which can be another 2 months. Yeah, so I work with NAMI. We have a lot of different programs for family members. We have a program called Home Front. I'm a Home Front instructor as well, just so we can speak with that veteran and that family member and let them know exactly what resources are available. And all of our programs are free, but what that family member and what that veteran will get out of the it's a 6-week program. It's just a chance to talk with somebody and get the resources and get the help that they need. Because I'm going through the same thing right now with the same VA. And when I reached out to 11 Alive and the local news reporters there, nobody at the VA wanted to comment. But then nationally, every time you hear a report about the VA, they say how things are getting better. But us on the inside know that it's really not. So within NAMI, we have a lot of different programs or resources for family members and caregivers. And NAMI is all throughout the country. You can go to www.nami.org, put in your zip code, and find what's called a NAMI affiliate that's closest to you. And we have internal databases that if we have a service that we need, that you need, and we can provide, we will try to find another nonprofit that'll give you that service or program for free.
Okay, thank you.
I have a question. I'm an active duty spouse member myself, and we just PCS'd a year ago. I was placed on antidepressant anxiety medication at our last duty station. I came here, and my current PCM wants to take me off of those and for me to go talk to behavioral health. However, behavioral health is at the NT of district active duty members, so we're having to go off post. If they take me off the medications because they refuse to continue those medications, what am I supposed to do, or how can I convince my PCN to let me continue my medication until I can see a mental health provider before anything, gets worse or anything like that? I mean, I understand you don't want to be on medication. I don't necessarily want to know it either. However, it's better for myself and my family to be on the medication until I can at least go talk to somebody about, life and whatever. So how do we communicate to our PCNs to continue that until we can get to the mental health provider to discuss things? And I get that. I mean, do you use the portal? The portal to communicate with your PCNs? No, I choose the documentation. Message them in the portal and say, so I'm understanding that you want to take me off of my antidepressants and my anti-anxiety medication because you want me to see behavioral health when I am telling you that I need these meds to function. See what they say. And get a new PCL. I cannot get another PCL. I've tried 4 different times to try care as the patient advocacy downstairs at Mark will not being the new PCL. But you are supposed to go through the system, though. You don't have to go through that. So they're denying it in the track care. In the child system, they'll say there's not any other PCMs that are available to take on another patient. This is really what the heck. But I was talking to Farrell Kelly. I
think you may have an answer. Raise your hand, please, sir. There you go. A mic is coming your way.
Outreach program coordinator for child and family behavioral health at Barnard Community Hospital. If you see me afterwards, we'll resolve that issue. And good.
So I think what you said was child and family advocacy, you'll be able to help. So for behavioral health, right?
If it's retirees, and we will resolve that.
Okay, thank you, sir. Okay, Will? Yes, sir.
I'm going to use my NCO voice this time.
Love it.
Here's the problem. Her problem is not unique. I hear it all too often. People come from other installations that are well diagnosed. They get here, they get a PCM. I'm going to take you off medication that another doctor's prescribed for you. That kind of nonsense has to be stopped, especially when it comes to mental health. We can't keep taking people off medication because you're not familiar with their case. If you have their record, you see what the diagnosis has been, let them stay on that medication until the behavioral health can confirm that's what they need. But pulling somebody off needed medication has got to stop.
No, thank you. Thank you for that. And I think what we're really talking about is the importance of continuity of care during transitions. And so that's an area we know that we can do better and we need to do better. I was just going to ask too, if you're having difficulties in primary care, if there is a primary care behavioral health person located in your primary care clinic, they will see you that same day. So we've built the access that they will see you the same day that you need to, and they have the relationship with the PCM where I'm wondering they could help advocate for you as well. So just another person potentially part of your healthcare team to try to advocate in transition program, again, can also help with continuity of movement between bases, and maybe try to help kind of arrange outside care as well. But definitely sorry that is the experience you're having. It's hard for me to comment on someone else's medical treatment planning or their decision making, but I'm still sorry that you're having that experience.
Okay, so since we also have substance abuse on the panel, so Harry, I'd like to get you to just give us an overview of what services are offered, typically on base, off base, just from your perspective.
Well, I can speak about off base. I work with New Horizons, and New Horizons offers three key services: mental health, substance abuse, and developmental disability services. Our substance use program, we have an outpatient program, and we have residential services as well. It's for the community, and one of the things I found out since being here, New Horizons, we're not connected as much as we would like to be with the militaries. Of course, those active duty service members are not going to really access our services. I've been working in residential services for about 13 years now, and probably on both hands, I can count the number of veterans that we've actually had their access in our services. So right now, we don't have a lot of influx of individuals, whether it's prior service or active services, that are benefiting from our services. So that's kind of what we have. But our program, my particular program, and as a program director, is residential services for substance use. And, we do the early interventions, relapse prevention. Then we have the aftercare program that we can offer. So those soldiers who are transitioning out, and if they don't have it, or family members, they can definitely benefit from our services. So we just want to make sure that everybody know that we're in the community. Very much aware that, with the military, like I said, with active duty soldiers, they have service that they use. I use Martin Army myself as a veteran. I also have utilized the VA clinics for some of the services. I've had a few individuals who had went to the VA, and because of the duration or the time to get in, they have actually came through and utilized some service with New Horizons. But that's kind of what we do. I don't know, Susan, want to add anything?
I always want to add something. New Horizons is a part of the state of Georgia Department of Behavioral Health and Developmental Disabilities. We are outpatient services. We are a sister agency with 22 other community service boards across the state. We serve 8 counties. Harry talked about some of the substance abuse services we offer. We also do medicated assisted treatment for opioid use disorders from one of the few locations in this area that does medicated assisted treatment for opioid use disorders. There was a question about school services. We have school-based mental health services in Harris County, Georgia, Chattahoochee County, and we call them our southern counties. It'd be Randolph, Stewart, Whitman, Clay. We find that school-based mental health services are going to be the way to go in the future for
meeting the needs of children and adolescents in our school systems. A lot of times it's difficult for parents to get the child out of school, take time off of work, get to an appointment, and school-based mental health services are really a great way to go. Our psychiatrists are there through telemedicine, telehealth, but we have mental health professionals embedded in the school. We are part of the public mental health safety net. So the majority of the individuals that we see are Medicaid. I would say 65% of the individuals that we see are on Medicaid, and then about another 30% of the individuals that we see are, we call them grant in aid. They have no way to pay for their services, and through the benevolence of the state of Georgia, we're allowed to bill for services for these individuals, and Georgia pays for them to receive services. We have a very small percentage of individuals that are on private insurance. We have one provider in our services. We have 6 psychiatrist providers on staff, and one of them is paneled with TRICARE and does see individuals through the VA. But I think she only has one individual that she sees through TRICARE services. But that's a little bit about us as the community-based provider. We do other things too. I was passing out a flyer. We're going to have a mental health first aid training, community awareness, talking about stigma reduction, getting people into services. Those are things that we really like to do in the community. You can't treat mental illness if you aren't talking about it, and that's where you have those conversations of courage and people needing to know what their resources are in their community for services. We partnered with UGA. They have a grant to do mental health first aid training with a focus on veterans. You may not be able to come to our training in November, but if you contact the folks at UGA, they'd be glad to come to your community and provide this training for free. You'd be surprised how many resources we'll pull together when you start talking about suicide prevention and awareness for veterans. We've got the space donated to do the training. We've got meals donated for people that attend the training. So reach out. There's all types of community partners that can help you around issues. And those people, I was hearing something today on the other side of the wire, those community partners on the other side of the wire are always willing and able to help veterans. Freedom is not free. It costs people dedicating their lives and family members dedicating their lives to military services. And your communities are very appreciative for all the sacrifices that you make.
Ask me that question, please. Can I take you somewhere as a young soldier, as a young pup? If I'm dealing, I'm going to use myself as an example. If I'm dealing one with mental issue or drug addictions, will I feel comfortable? Do I trust comfort to you that will be confidential what I said, that it won't get back to your chain of command and ruin my career progression? Thank you for allowing me to share.
I'll answer for us. Again, I would say yes. If you're coming to us in accessing our services, there's no reason for us to report back to the chain of command because we're a community-based organization. So the confidentiality would be there. So we're not going to actually go back and talk to your chain of command. And I know for soldiers, the warrior mentality, again, I did 21 years in the military. And so that stigma of, drive on, keep pushing no matter what. You don't want to admit that you have something going on. Probably this young lady that stood up and talked about her mental health issues and wanted to make sure she could stay on the medication that she needs. You don't get a lot of soldiers or a lot of people who will say they need to continue with their medication. Most folks want to get away from it. And she did state, I don't want to be on it for the rest of my life. For now, I need it. And she knows. But we have probably with active duty soldiers, again, it's been a while, but even when I was in, they don't want to take the medication because the stigma that's associated with. And that's kind of what this is all about, the communication. Having that talk with that young soldier and letting them know that, there's no shame in taking medication. And for those who are in active service, hopefully, there won't be any repercussion for them doing that. They want to stay in. And I heard that, there's a shortage right now. And and we're going to find every little thing to identify their soldiers not being fit, then that's going to not make it good either for retention and keeping people in. So but to answer your question, yes, if with our organization, you could be assured that it comes to you, we would not report back to your chain of command.
I just want to add a little bit to the discussion of DOD and stigma, because we do hear about that quite a bit. And so it's important for us to acknowledge that certainly there is stigma around seeking mental health services. That's not unique necessarily to DOD. That's our country struggles with it, quite honestly. But there is a little bit of good news. So the generation that is coming, so if we look at Generation Z, and we look at some of our younger population that's now coming into the service, they're much more likely to seek mental health services. So that's great news for someone like me that is looking to identify those folks and pull them in and help treat them. And so I think we are seeing a change in tide there. One of the things that General Crossley continues to tell our team in the behavioral health is just we need to really change the way that we view mental health. So mental health is health. You cannot have good physical health unless you have good mental health. And so we always want to kind of pull them apart and talk about them separately, but we need to start to change that discussion, not just within DOD, but really within the nation, because a person that is struggling, most folks hit a bump in the road some point in their lives and they're struggling. That's normal. And so being able to develop and help support each other, whether from prevention and community through to when it gets to the point of starting to actually impair you functionally in your relationships and your work performance, we need to get you into the system so we can help you and we can help treat that mental health condition that's developing. But I think really going back to, so stigma, one of the things, so we've got a population that's going to come in a little bit more, which is great. We need to really start to campaign and message that good mental health is just good health, period. And then also, if we have not done a great job advertising the fact that if you come in and you seek mental health services, it is extremely low risk for you to have career impact. And that's hard sell. The data is there. It is proven. It's just that there's stories out there, right? And there's anecdotes, and there are outliers that have had career impact and had some negative consequences. But as a whole, what we see is that if you come forward and you seek services, voluntarily especially, we have a really good chance of helping you return to full duty and helping you become, return to being a successful member of the service. And so just wanted to mention that.
So Dr. Elliott, at the end here, could we pass it down? I'd like to call on him to what is he seeing in this arena? How has he dealt with it? Things of that nature.
If I can, though, let me
please
address.
Sure.
As far as impact, the intent for the active component soldier is not driven for negative consequence, but what a lot of people seem to fail to realize is whenever we have soldiers that come up positive for an illegal substance, or you have an alcohol-related incident, especially if it is impacted on the installation or depot, it's mandated in the regulation AR 600-85 soldiers that they have to be referred to what is now known as SUTCC, our substance use clinical care. And so in that, when they are referred, they have to be screened. And what happens is in the screening, due to the fact that it was for a negative circumstance that has happened, what our regulation dictates is they devise what's called rehab team that is inclusive of the commander of the soldier. So now that brings the command into the picture so they have visibility of what is occurring with the soldier to be recovered. So in that now, it's not like they're putting on blast what that individual has as a substance abuse problem or addiction or alcohol, etc., but it is mandated that that commander has to have visibility because they have to know the effectiveness of their command because they still have a mission that they're responsible for. And as long as that soldier is still part of their command, they have to have visibility of what's going on. So in that means they're going to have visibility of what's going on with the clinicians because they have to devise a treatment plan for the individual. And we want the commander to be supportive of that individual to make sure that they meet what's required for treatment to see it through. So in that, I'm not answering for all commanders as to negative impact that comes out of it, but I'm just making you aware there are certain things that's in black and white through regulation and policy that those things have to be connected for the chain of command to have visibility.
Okay. Thank you, Dr. Hart. One more question, then I think we're running up on time. The panel will be up here afterwards as well as down in the vendor hall.
If we could just do one more question.
Dr. Elliott, I know you and have worked with you here at Fort Moore. Minutes. You're riddle. As my commander, do not fire me. I hear that was so eloquent when you put that. However, when soldiers come up positive for drugs or alcohol, what you say is how it should work. But with the old guard in place, that's not how it works. Because you have multiple things up there, like with the Delta 8. Regulation says I can counsel you, I can reprimand you, I can take UCMJ, but I'm not required to separate you. But you got multiple old guards that said, I don't care what it is, it's drugs, you're getting up out of here. My commander for traffic will tell you, senior leadership, you come up with drugs or alcohol, go ahead and retire. In the conversation. Problem is, no one trusts the policies anymore. That's the bottom line. A young soldier, as he said, young greedy, right? As my wife calls them, babies. We think about it. We have some people that want to crush them, some people want to keep them. If we have a junior NCO, up or down. Senior NCO, senior officer, back he wants the house. Okay, how many years you give him this country? There's an inconsistency how we treat everybody. There is no generalized plan. Yes, we have to treat them to set C. Certain drugs and alcohol, we have to initiate separation. Mandated. I have no way around it. You come on twice on alcohol, 12 years, you gotta go. Wait 12 months, you gotta go. And that's mandated by Congress. I have no way. But there is no set thing. You know, I had a sergeant major, I would follow anywhere until a firewall. He cared less. He dropped his head, he had retired. I'm confused. We don't live in a perfect world.
Yep. General?
So I was called out when I thought, that's all. Thinking about every dying, I would never drill sergeant, but I'm using my drill sergeant boys. So I want thanks for your service, and thanks for your concern. I've been in for 36 years now, so I see a little bit of both ends of the spectrum. And just offer a little bit of comfort, because I'll say I trade out, we also won't lead the development. So I won't dispute part of what you said. But what I will say is I see as the pendulum is moving in the right direction for the leaders now. And I'm one of them that give the classes to the leaders and the sergeants too. One, erase this thing that could be associated, I'm going to get this go up in a minute, but that are truly legitimately associated with that leading mental health and needing mental health. And I'll highlight one of our divisions that did a pilot over a year ago, and their words try to make accessibility for mental health just as easy as it is going to get you a Cat 3 dental chip. It's health. And then acknowledging whether it's due to combat-related issues or family issues, and mental health could be triggered by something, a death in their family and a whole bit. We see all this in the recruiting space. So where I'm going to help eliminate the stigma and the problem that you well said, illustrated, and I'm not going to dispute that it didn't happen at a point, well, is our leaders giving a damn, carry, removing the stigmas that, I went to go seek mental health, I'm going to lose my security clearance. That's not true. Getting rid of those stigmas, and that either through local support, contractor support, just available tele-support, as mentioned by the Admiral there. Admiral has promoted you.
Merry Christmas.
Public health service here. Making that available, accessible health, because it is indeed health. We're rolling into our health and holistic fitness as well.
Even a new trainee, before they join, I found out, hey, I lost a parent while in high school. Their states require them to get mental health. Doesn't mean you have a problem. You just need help. So it's better acknowledged on the drug and alcohol. The drug and marijuana. There are red lines. Now, if you can associate the two, I had a mental health problem, so I smoked weed, permitted as an expression. If you got a DUI and you're 5 times over the state limit, once or twice, then you're probably going to get put out. There's a difference between discipline, because you messed up, and have a true mental health issue. It's a long way of saying we've all fully acknowledged that. The stigmas must go away. Religious health, physical health, mental health, and behavioral access to behavioral support is a must. Or families and our soldiers, it is a true retention issue as well. I can tell you for sure, this guy and my peers are taking it serious. I know that wasn't on the agenda, but I felt up.
Thank you, General. Okay. Okay. You have been so patient. You get the last question. And everyone, again, will be here after we close.
I'm Captain Rosowski. I'm a behavioral health officer for the 197 Training Brigade. I was here at Fort Moore, and then I went up to Alaska for the behavioral health crisis, and now I'm back. I have a brigade commander who has done an exceptional job saying, Ross, I want you to go out there and find the need and crush it. He is so friendly to behavioral health. He'll tell any room that they should get better while assigned to Fort Moore, and their family should get better. I have taken it on as a brigade officer to go and find these problems or these soldiers that need help, and I cannot give them help. I know all the resources. I know Teleline. I have a soldier who was refused care from military one source because they needed medical counseling. I have now put in a referral twice for it to be denied. I have went to the 4th floor where I used to work. I know Mr. Tolliver. And I still can't get these service members care that they need. So as a licensed mental health professional, I'm saying, hey, I need to send them off post, and I can't get past that red tape. So who do I need to talk to? What do we need to do? Because everyone's saying remove the stigma to where they're saying, yes, I want the care. And they are telling me, yes, I want the care. And I will work 60 hours a week as a dual military couple if I need to. But I can't give them all care, and I recognize that.
Sure. So I think one of the things that you're bumping up against is that an old way of doing business, right? And so one of the things that we do, and we would like to be able to deliver all behavioral health care to every single active duty service member that requires it. But as we've talked about, it's certainly the demands is exceeding our capacity, and we don't have it. There is nothing in policy or law that prevents you from putting in a referral to behavioral health. Your behavioral health clinic here at the MTF needs to approve it to go off-site. And so I'm happy to, if you want to get with me after, we'll work that through. So that's an easy phone call to be able to talk with the behavioral health leadership, just to make sure that they understand that they have the authority to sign that referral to allow them to go off-base. So there are going to be circumstances potentially with very high risk that you're going to have to keep them in just for readiness reasons. But outside of those, the majority can still be referred. 18% of active duty service members are referred right now and receiving their behavioral health care out in the network. And so it's happening. So we can do that.
Okay, so I'd like to say thank you. Thank you very much. We'll be here after the closing. Thank you, Panel 4. You did a great job. And thank you for all the great questions.
Let's give Mr. Dickinson and his panel another round of applause for the. I'd like to thank all of our panelists and moderators, as well as Blue Star families, and of course you, our audience, for participating in today's summit. Please welcome back to the stage U.S. Representative Sanford D. Bishop Jr. and U.S. Representative Kathy McMorris Rogers for their closing remarks.
Okay, well, just a big thank you. Thank you to all the panelists, all the speakers. Tremendous insights that you have provided us today. And thank you for being here, for giving us your time. It's just always, that's such an important part of this. And then a big thank you to Fort Moore for hosting us today. Did I get that right? Okay. I was like, oh boy, Fort Moore. And
a tremendous facility here, the museum, and it's always great to be here. But most of all, thank you to everyone that participated. Thank you for your service. Thank you for so many who have stepped up and put on the uniform, are currently serving, and those of you who continue to help meet the needs of our service members and their families. This military family caucus is here because we believe in the importance of the family. We believe in the importance of the military family, that it is the strength. It is the strength of our military, and that's the strength of our nation. And what you do to keep us safe every day is not anything that we take for granted. So we learn. There's a lot to take away. I've already been talking with my team and my partner here, Mr. Bishop. We're going to continue to work with you, and it's just always great to be able to identify the gaps and then continue to go to work to address those gaps. That's the American way. The Declaration of Independence, or maybe it's the preamble. Actually, preamble to the Constitution says it's we the people. It's we the people, in order to form a more perfect union, establish justice, ensure domestic tranquility. But it's all of us. It's we the people, and none of us are perfect. But we continue that search for a more perfect union, and each one of you here today, by participating, you're being a part of that search and that continual effort to provide a more perfect union to everyone. So thank you very much. Good to be with you. God bless you.
Thank you. Thank you again. I want to thank everyone for participating in today's summit. It means so much. And I want to thank the panelists, all of the panelists who've helped us raise awareness about the important resources, programs that are available to our military families. I want to thank you, the audience, for joining us, because by sharing your experiences and your questions, and we've had some good, stimulating questions, you're helping us find ways to improve the ways that we can support our military families. I want to thank Blue Star Families. They've been great partners from the beginning. Let's give them a round. Since we started this caucus, Blue Star Families have been right with us as partners, and I want to thank them today especially because she helped set the tone for each of our sessions, and you provided factual data that served as a logic point for the various discussions that we've had. I want to thank our moderators. The insight and the perspective that guided the discussions and fostered the conversation between our presenters and the audience was superb, and it stimulated the discussion. I want to thank our honored guests, all of you, for taking time from your busy schedules to support this summit. I want to thank the many leaders from Fort Moore who helped spread the word about today's event. We started the day with a standing room-only crowd, and we enjoyed a robust audience throughout the day. I want to thank the National Infantry Museum and Soldier Center for welcoming us so that we could host this event here today. Your staff helped us make this day possible, from setup and technical support to lunch and the logistics. I want to again recognize and thank Joe Brito. He is a command. He has a major command, and he thought it not robbery to come and to spend time with us. And his responsibilities are heavy. He has gone out and come back several times during this conference to attend to other responsibilities associated with his duties. But he came back, and he's here for the closing, and you were right on time with those last comments about the leadership, because I have experienced, and I hear as a member of Congress, that our military is doing everything that it can to change the culture as it comes to the stigmas attached to mental health and mental illness. It's a long process, but that is an ongoing effort,
And I think the general reflected that in his comments. I want to again thank my co-chair. She's been a great partner. And of course, once we launched this caucus, it was contagious. So we had counterparts in the Senate who established the Senate Military Family Caucus. So we have it going on the House side and the Senate side. And of course, we have great partners in the executive branch, and we thank you so much for that. We look forward to returning to Washington to share what we've heard today with our colleagues and with all of the other policymakers so that we can really, really make a difference. Now, I want to thank my staff. First off, let me ask you to give a round of applause for Will Abner. He is a military fellow, and we have enjoyed military fellows over the years, but he has done a tremendous job in organizing this event, working with Congresswoman McMorris Rogers' staff to make it happen. And it has come together, and I think we had a great work product, and so I want to thank you again, Will, publicly. I want to thank Jack Bryan. Where's Jack? Is Jack in the room? Stand up, Jack. Jack headed up the creative design and the social media efforts along with our friends from the House Creative Services, David and Ike. They're here today recording and photographing today's proceedings. I want to thank my district staff. It was all hands on deck with everyone pitching in. Paul Fryer, who came up from Bainbridge, Chris Kelly, Gerald Washington, Latanya Jones, Janelle Harper, helping us make sure all corners of Middle and Southwest Georgia are aware of this event and for their support today. And I think Haig, my communications director, is back there from Washington. And of course, he is doing what he does to make sure that we get the message out. I want to thank Miss Peggy Sagal, Miss Tony Pickell, Christopher Drake, as well as Victoria Jones, who is a Wounded Warrior Fellow in our office, who helped organize the lunch, the vendor workshop, and guest logistics for today's event. Finally, I want to thank my Chief of Staff, Mr. Kenneth Cutts. He served as Master of Ceremonies today, and he helps to ensure that our team is ready, willing, and able to assist our constituents, including our military families, every day. And of course, I have to thank my wife, Vivian, who keeps me going and keeps me on track and makes sure that I stay on task. As we close today's summit, we look back at what was shared, what was learned, and we look forward to the opportunities ahead to serve those who have made this ultimate sacrifice for our country. And we want to honor and to celebrate them and to make sure that they have all of the resources necessary. Thank you all for coming, and I want to just close with a thought similar to that my partner closed with, but to mine in the form of a poem. It is my favorite poem. It's called A Bag of Tools. Isn't it strange how princes and kings and clowns that caper in sawdust rings and common folks like you and me are builders for eternity? Each is given a bag of tools, a shapeless mass, and a set of rules, and each must make ere life is flown a stumbling block or a stepping stone. All of the people who have come together today, who've made today possible and who have participated, you have not been stumbling blocks, but all of your questions, your concerns, your comments, and just being here
have been stepping stones for better opportunity and for better outcomes for our military families, for our military, the resilience of our military families, and we thank you so much for that. With that, I will turn it back over to Mr. Cutts for further instruction. That's Can I get you guys to move? We're going to have to retire the colors. They're going to have to go this way. Sorry about that. So as I prepare, we're going to have to retire the colors. But let me just say, I need to recognize a few other people. We have our Senate offices here today. I think from Senator Ossoff's office, Ebony Morris-Key was here earlier, but she had to leave, I believe. But we also have from the office of United States Senator Raphael Warnock, Miss Brenda Williams. So I would like to recognize her at this time. As we learn, share, and strive to build resilience and enhance well-being in our military families, we should all go away from here remembering our theme for today. Together we thrive. I am sure that after all that we've heard today, we have developed a deeper understanding and appreciation for the service and sacrifice of our military families. Ladies and gentlemen, this concludes our summit. But would you please stand as we retire the colors? Thank you all for your presence and active participation today. May God continue to bless each and every one of you. And in times like these, may God continue to bless the United States of America. Thank you.
Good.